So your February exams are, your exams are starting in Feb. When are they ending, Doc? Feb 11th. And practicals? 20th, so that they are saying March first week to release you into housemanship. 1st March. You are into the 1st March last practical exam. Mostly 2nd week of the March you may be into the internship. Huh? Minimum 20 days is required to take rest and come back to join housemanship. No. Now the NEETPG eligibility is 3rd week of March. No. So 20 days, I wonder, really do they give 20 days of time? But anyway, your senior batch is finishing only on March 31st. March 31st, very good. So on January 7th, we are starting a everyday session for the NEETPG with the final year subjects in the initial part, live interactive session, 5 to 8, where we have once more a review from an entrance point of view in the gynaecs, medicine, surgery, and once March 31st is over, we will be giving one schedule. Probably if you still have energy by then, you can always participate starting from Jan 7th, a live session. So how many of you are having internet with you? No, because we want to give to all of you, because writing in DVDs of this regular updated video is a difficult job. So instead of that, we will give you all one free account. So that from home you can log in and then can start accessing the video library, where live sessions also you can attend. Even during internship, the main challenge is you will have night duties. You will not be able to attend a live session every day, Monday to Friday. On every Saturday we have a subject test and Sunday a grand test. So Monday to Friday, even in internship, the live session is available as a recorded content, or from home or from hospital you can participate if you have a laptop. So that is the whole idea. We conduct it as a 30-week session, Jan 7th to September 1st week. After that 2 months we give a practice of every week mock test, and November is once more the NEETPG. So this time MD entrance is pre-term, ending the internship is post-term, and probably 2 months you will do internship with a pride that I am going to join the same hospital as a postgraduate in a particular X department while still doing internship. That is a matter of pride. Why? Because you can tell, since I got seat in gynaecs, even if I don't work in dermatology, no problem. And those last 2 months posting in the gynaecs only, and you got seat in gynaecs. During your internship, you need to work extra to show that you are a good student joining the post-graduation. So there is always a trouble either that way or this way. So good, doctor. Now, coming to the urinary tract obstruction, yes, how do you diagnose? Ultrasound is the simplest examination which can be able to identify very sensitively hydronephrosis, but there can be false negatives, is what you need to appreciate. KUB can reveal the stones. IVP can be a wonderful investigation, gold standard to identify the obstruction, especially of the ureter. But for IVP, why you are always careful about IVP? In IVP we are injecting contrast, and that can lead to contrast induced renal dysfunction. So that is the reason in pregnant, those allergic to contrast, you need to be careful. You can do a cystoscopy to evaluate whether urethra, bladder are okay. Then you want to do CD scan to delineate if it is not, if you are not very sure. Then a very important investigation is called voiding cystourethrogram. Basically, you will be passing the contrast through urethra into the bladder and make them to excrete it, and you catch serial radiographs, so that you can be able to identify any mass in the bladder or stricture of the urethra can be made out. And what is this investigation called? Voiding cystourethrogram is basically indicated, especially when you are suspecting a lower urinary tract obstruction as the underlying cause. So how do you treat? Depending upon the underlying cause. Whatever, you need to put a catheter if it is an acute obstruction, and you need to do urethrotomy and dilatation if it is a stricture, prostatectomy if it is BPH, and a nephrostomy if it is a upper urinary tract stone responsible, and etc. etc. Now doctor, the next main thing about urethral obstruction, urinary tract obstruction, you need to know is how to classify the causes between above uretero-vesicular junction and below the uretero-vesical junction. That's more than enough. Now doctor, prostrate cancer, very common malignancy which we find in geriatric population. 95% of them histologically are adenocarcinomas. What is the risk factor? Every aging man is a risk factor to himself. Positive family history, exposure to pesticides and herbicides, they are all considered to be some of the risk factors. Now doctor, there are 3 investigations, combination of the 3 will increase the sensitivity specificity for the diagnosis of prostate cancer. PSA, digital rectal exam, and transrectal ultrasound, the combination. So how do you make use of these 3? Suppose if the prostate specific antigen levels of the patient is more than 10 nanograms, this algorithm we follow in everyday diagnosis in the OP when you sit. If PSA is more than 10, then whether digital rectal examination you are able to feel something or you are unable to feel something, doesn't matter. It becomes an indication for transrectal ultrasound along with the biopsy is indicated. If the digital rectal examination is when you have done PR, if the digital rectal examination is able to feel a nodule suggestive of a prostatic malignancy, then irrespective of PSA, PSA may be 5, PSA may be 2, PSA may be normal, irrespective of it, it becomes an indication for truce with biopsy. If the DRE, digital rectal examination, is negative and the PSA is less than 4, for such patients you tell come next year, annual follow-up is indicated. If the PSA is 4 to 10 and DRE is negative, then there is always a controversy, and as a clinician you will decide whether this patient is possibly a case of cancer or not. Now, how does the patient of prostate cancer will present? None of them are asymptomatic. You know, there are 2 entities, BPH and prostate cancer. BPH is central, prostate cancer is peripheral. In the adenomatous tissue of the prostate gland, peripheral areas will give rise to prostate cancer. Periurethral central location, say benign hyperplasia will originate, is the principle which you should not forget. There can be a metastasis to the bone or to the lymph node. Later stages there can be urethral obstruction, prostatic urethra, leading to difficulty in voiding, dysuria, increased urinary frequency, etc. etc. If they are matched to the bone, bone pain can be there, especially vertebral body, pelvis. Then weight loss can be there, and any elderly patient with a severe low back pain always deserves one good X-ray. Why? Because elderly person with a prostatic cancer metastasizing to the bone is a very common cause for a severe back pain, which you need to fundamentally evaluate. Now coming to the digital rectal examination, when you feel the carcinomatous prostate, how will it look like? Hard, nodular, irregular. however described, unless you feel once, you can never be able to really appreciate it. Normal prostate, very reasonable question. How does it feel, sir? Feel your thenar eminence. As much soft and hard it feels, even a prostate will also feel when you do the digital rectal examination. Feel your knuckle. As much hard your knuckle feels, a prostatic cancer looks like. It's very important. And whenever palpable, the rule is half of them have already spread beyond prostate. Another unfortunate news. First, to feel it itself is a sad news, and you can't feel it in the early stage. You felt it like a knuckle and already you are able to feel it, means it has grown enough that it is beyond prostate in about 60 to 70% of people. If you feel it and you felt it like a knuckle, then you need to get a transrectal ultrasound irrespective of the PSA levels. That is the important rule which should not be forgotten. Now, what is the importance of PSA? PSA is a useless, insensitive, non-specific investigation. Why? Because if you massage the prostate, PSA can elevate. If you do needle biopsy, PSA can elevate. Cystoscopy, BPH can cause not only cancer, PSA elevation. Any inflammation, prostatitis, and with advancing age, anything can cause an elevation of the PSA. Hence they said, don't use PSA as a screening test for cancer. If it is elevated, you run and do all investigations. It may be simple BPH. It may be a severe carcinoma growing and PSA may still be silent and sleepy. Hence, its screening value is doubtful. Hence they said, adjust the PSA levels with the age of the patient. Age adjusted PSA will help you better. Then PSA velocity. That is, it is increasing, but at what rate it is increasing when you serially evaluate also is an indication to say whether it is due to BPH or whether due to prostatic carcinoma. Similarly, you have a free PSA, protein bound PSA. If you look at the normal cells, whatever the PSA that they produce is more likely to be free in plasma, whereas prostatic cancer causes a elevated PSA which is a bound PSA to the protein. That is another important clue to say. Then compare the level of the PSA with the volume of the prostate gland as measured by transrectal ultrasound, and you calculate PSA density, which gives a better value, a better suggestion about the prostatic malignancy.